And that was coming partly from the fact that 16% of those patients developed second primaries, and also they observed that 45% of deaths were there caused by not by the original tumor, but by other tumor and comorbidity. Now, another randomized trial was reported by the group of Faki in Bombay, Tata Memorial. They did a randomized patient to hemiglossectomy and radical neck dissection on the same side, or hemiglossectomy alone. And they observed that in the group of the radical neck preventively, 1/3 of the patient had lymph node invasion, but an additional 4 patients had contralateral lymph nodes appearing in 4 months. In the hemiglossectomy alone, there were down the line 57% of lymph node invasion against, if you add this to this, 47% of node invasion. So the disease-free survival in those two groups was not significantly different, and that was all true for each stage respectively. But what is more important in this study is that the authors looked to the depth of invasion in 51 patients where it was available. And in fact, to summarize, they saw that in patients where this depth of invasion was more than 4 millimeters, the survival was worse, twice worse as in the patient where the depth of invasion was less than 4 millimeters, whatever the treatment. So that is, I think, an interesting randomized trial published in 1989. Now, very briefly, for the sake of the discussion after that, lower alveolar ridge and retromolar trigone T1, T2 cancer, you need white nodal excision with marginal mandibulectomy, close proximity to the bone, infiltration into the masticator space, nodal invasion, nothing new, it's the same as in other sites. Radiation can be used also as a mono treatment or be kept for adjuvant for close and positive margin and lymph node invasion. So you can use radiation adjuvant, and then you have a staging of the surgical specimen, or depending on the school or the institutional habit, you may use surgery as salvage after failure for radiation. The same is true for upper alveolar ridge and hard palate cancer. This is a study reported by the team of Memorial in 1981, and I give you the figures to have a gross idea of what was achieved at that time. But one more time, surgery gives you a specimen, and you may stage the depth of the invasion and all those characteristics by the fact that you have a specimen. And for buccal mucosa cancer, which are more rare tumor, usually you can perform transoral resection and cheek flaps or other kind of free flaps if the resection is more large. Nowadays, those give very good functional results. And next is advocated for T1 or even T1 lesion, T2 or T1 lesion with a depth more than 5 millimeters, or if the muscle buccinator or what is invaded with this kind of survival. Here you have one of those patients that we operated recently. You see that the tumor is not very big, but it's blocked the Stenson duct. You have a salivary blocked here in the duct, and wide resection. The tumor was more than 6 millimeters in depth, and we had to do elective lymph node dissection, which was positive for 3 nodes, and radiate the patient with good functional and aesthetical results. So radiation can be used also for those tumors, like I told you. And one more time, if you have a surgical specimen ahead, you can define all those important factors to advocate radiation or chemoradiation for high-risk tumors. So In conclusion, I would be a little bit provocative to maybe stimulate the panel and the audience. Prognostic factors in oral cavity, well, T size remains what I would call an all-timer. It's important, but it is not all. The depth of invasion is more informative, as are perineural spread vascular invasion. And involvement is a state of emergency for prompt and multidisciplinary aggressive treatment for those patients to achieve locoregional control. For my point of view, the N0 neck should not be a cause of debate anymore on what is to be done in a randomized trial, because all those characters and prognostic factors will give you if they are routinely reported, and that is a cause of multidisciplinary not only treatment, but multidisciplinary team with communication with pathologists well educated and with a checklist. And if those characteristics are routinely reported, they will be the basis of a planned treatment. Well, that will be it. I thank you for your attention.